attendees are in listen-only mode. Welcome to GoToWebinar, Web Events Made Easy.
Hello. Hi, my name is Claire Sinclair and I head up the professional development team here at Cardiff University. I'm delighted to welcome you to Cardiff University's free webinar that we're running to give you a flavour of the type of sessions that are included within our Assessing and Managing Medical Risk for Insurers courses. These courses are a mix of online and face-to-face teaching, so delivering this taster webinar seemed an appropriate method to use to introduce you to the type of teaching you can expect on the course and the education experience you will have. We'll give details about the courses that are running in May and June at the end of the webinar. The webinar will last for approximately 40 to 50 minutes and aims to provide you with a useful learning experience which will give maximum impact while causing minimal disturbance to your working day. This taster webinar is a first for us and we're really pleased by the take-up response. As you know, we set our target at 100 places and I'm delighted to say that all places have been taken. And in addition, we know that a few companies have registered and are showing the webinar on one computer that is visible to a few staff so that they can all watch together. During the webinar, we will be tweeting key points and also a recording of the webinar will be made available later on in the day. So a few domestics for the session. We'd love to make this session as interactive as possible. You'll see on your screen in the top right hand a box which you can type questions or comments. We have a team on hand to respond to these, be they technical or related to the presentation, so please don't hesitate to drop us a line. There'll be a brief survey once the webinar closes to gather your thoughts and feedback for future events, so we would very much appreciate you taking the time to complete this. So I'd like to introduce the webinar and Dr. Nick Niven-Jenkins, who will be delivering the session. Nick is the Education Coordinator on our Assessing and Managing Medical Risk for Insurance courses. I'm sure many of you will have been lucky enough to have attended a presentation by Nick before and therefore will know that he encourages participation and questions. As mentioned already, there is the option to pose questions or just comments to us via the chat or questions function. We shall try to answer as many as possible during the webinar, either via text or by interrupting Nick to respond to the questions if relevant. Any questions that aren't answered during the webinar will be answered once it is finished via email. In addition, Nick will be using some interactive polls with multiple choice questions which we'd really love to get you involved, so do respond to those. Okay, I'm going to hand over to Nick now.
Hello. This afternoon we're going to look at two common neurological conditions, Parkinson's disease and multiple sclerosis. We need to start off by thinking about things such as human movement. It's not possible in this short session to go through with you all the anatomy and physiology. Much of this is covered in things like the introductory sessions and the online modules. Basically, human movement is controlled by a complex motor circuit, as it's set up there, and involves lots of parts of your central nervous system, but particularly your cerebral cortex, your brainstem, which includes your basal ganglia and your cerebellum. So you'll see that really motor control is achieved by using mainly three neural structures: the pyramidal system, the extrapyramidal system, the cerebellum and basal ganglia. You can see on this diagram that the basal ganglia, which are an important group, particularly when we're thinking about Parkinson's disease, are nuclei that act as a cohesive functional unit that are situated at the base of the forebrain. this simplistic schema shows you how all three interact together in long tracts down to the appropriate level of the spinal cord. This next picture, particularly the one on the lower left, shows a coronal section of the brain. And why we've put this up is because the substantia nigra are labelled, and it's in this region that people with Parkinson's disease run into trouble. Now, movement disorders of the extrapyramidal system have two main types. There's either loss of movement, akinesia, or slowing movement, bradykinesia, associated usually with an increase in muscle tone, rigidity. There's also abnormal involuntary movements, dyskinesias, often accompanied by a reduction in muscle tone. Now, lots of these involuntary movements you'll know about. There's tremor, there's dystonia, chorea, and tics. They're all very common ones. So let's have a look at Parkinson's disease, which is mostly about bradykinesia and rigidity. Parkinson's disease is a progressive idiopathic neurodegenerative condition from the death of dopamine-containing cells in the substantia nigra. Unfortunately, there's no reliable test to distinguish Parkinson's disease from other conditions with similar symptoms. We've put a question up now before we go much further. What do you think is the main cause of Parkinson's disease? Have a look at the options and choose one.
Okay, the results are just coming in.
That's fine. The majority of you have chosen unknown, and you're correct. You're actually swapping around a bit and changing minds, but those of you that chose unknown is correct. It's almost certainly multifactorial, and in fact, some of the other parts, things like genetics, play a role, but a very small role. In fact, as you'll see on the next slide, it tends to occur where there's diffuse brain disease. There is a genetic predisposition, but only in about 10% of people. And you can see the list of non-genetic causes and the differential diagnosis of Parkinson's disease that we need to consider. So we'll have a look at the incidence and prevalence now in the UK. Okay, it's estimated that it affects about 1 in 500 people in the UK. And the prevalence rises with age. So the higher your age, the older you are, the higher the prevalence and the incidence. And it's particularly noticeable in males. Unfortunately, depression affects around 40% of people with Parkinson's disease. And in some instances, this can be a presenting symptom. Have a go at the test you see on the screen now. What age do you think it's the average age of onset for Parkinson's disease?
Okay, so results are just coming in there. I think, like you say, they're swapping over, aren't they? Yeah. It's a bit mixed there, isn't it?
It's very mixed. As I said, it's generally a disease of the elderly. So most cases start between about 50 and 70.
Yeah. Just to say that 52% were saying 55 years.
Okay. That's a bit low for the median age. It's actually 65 years. So that's fine. And the next slide, that's it, shows the incidence of Parkinson's disease. And you'll see that it does start around 50 or so and actually tails right off in the 70s. So about 65. So what characterises Parkinson's disease? Actually, it's quite a difficult diagnosis to make in many instances. But generally, it's progressive slowness of movement, bradykinesia, with the eventual loss of movement altogether, but this can take sort of 10 or 15 years, and it's known as akinesia. There's rigidity, frequently called cogwheel rigidity, tremor, usually at rest, and there's things like heel rolling, And people shuffle when they walk, so they've got what we call postural instability. They shuffle along. One of the notable characteristics is in shuffling they tend to get faster and faster and faster and often can't stop until they bump into something. It's important to remember, as I said before, that psychiatric problems, but particularly depressant, often occur in about 50% of people. They can get autonomic disturbances and pain as well. And this leads to significant disability, which in turn limits their social functioning. So the symptoms, they're basically due to a deficiency of the neurotransmitter in your brain called dopamine. This is mostly due to cell death, and as I've said before, the majority of cases we have no idea what caused it, so we call it idiopathic. We think about 20% are probably due to things like drugs and infections. Drugs play an important role in Parkinson's disease. Even simple everyday drugs, to doctors everyday drugs, like anticonvulsants and anti-sickness medication like Stemetil, chlorperazine or metoclopramide, they can all cause movement disorders which mimic things like Parkinson's disease. So what's the fundamental problem in Parkinson's? Well, it's death of the dopaminergic neurons in this area called the substantia nigra. In some people, you get a protein that you can see in their brain, and these are called Lewy bodies. This decrease in the release of dopamine leads to disruption in the neural circuits, particularly in the motor cortex. And so what used to be smooth, coordinated movement is lost, and people develop a tremor with joggy movements. Some cognitive functions are also lost in some people, so they have problems with knowing where they should be, what the time is, determining answers to questions. Many of them have problems with their short-term memories. So we've been through it. Answer the next question. What do you think is the main cause, or common cause, and the underlying etiology of Parkinson's disease?
Okay, so that's the votes coming through. Looks like 64% was D. 3% are going for A.
Okay, but it's actually D. It's loss of dopamine producing neurons in the substantia nigra. It's not in the motor cortex. Okay, now we'll look at the slide up there now. One of the important things to realize sometimes is that people can gradually lose the ability to produce dopamine in this area of these nuclei, but it's pre-symptomatic. In other words, they don't have any symptoms to begin with. It's only when the loss of dopamine reaches a critical level that they start developing symptoms. So you may well see reports about people who have odd tremors or flicking in a finger that's not put down to anything, and in fact it's the early stages of Parkinson's disease, but they're virtually pre-symptomatic. One of the reasons for choosing Parkinson's disease is that there are many movement disorders, and GPs tend to refer them all to a neurologist, and they often label them as Parkinson's disease when in fact they're not. So when you get GP reports, if there seems to be any doubt about it, and the person has seen a neurologist, which they should have, then it would be worth getting a neurological report or asking the GP for the neurologist's report. NICE has issued guidance to doctors about how they should deal with people that they feel have a movement disorder, in particular Parkinson's disease, and they need to be referred quickly and, if possible, untreated to a specialist, a neurologist. Neurologists frequently review the diagnosis because, as I've said, movement disorders can represent a range of different conditions. And you can perform challenge tests if you want to try and be useful in a differential diagnosis, but we don't often do that these days. So how do we diagnose it? Well, like many neurological conditions, it's actually a clinical diagnosis. There's a clinical examination where somebody takes a personal and family history. They then observe what the person does, because many people sitting down, you can watch them do this pill rolling with their fingers while their arms are at rest while you're talking to them. You can then do a general and neurological examination and look for things that may well cause a Parkinson's-like thing, like the medical history of the drugs and things that they take, as we covered before. NICE say, as I've written up here, that the routine use of imaging is not really recommended, but you can do some functional imaging, and one of them is called a SPECT scan. It's fairly cheap, and it's thought in about 50% of people. It gives an indication about the loss of dopamine. It's really a examination that involves a CT scan and a radioactive nucleotide. And what you do is you give them this by injection, and you can see on the CT scan the uptake of it. So as I said, you can do a lot of other tests. There are blood tests you can do. You can normally do MRI scans. You can do PET scans. What I've shown on this next slide is one of these SPECT scans. You'll see at the top is a normal person, and they've been given the radionucleotide in the middle two pictures, and you can see that the dopamine which stains red is missing or lacking in the middle pictures, and then just as the contrast is taken out of their system, they start to revert back to where they were before. So let's have a look at another question. How do we normally diagnose Parkinson's disease, do you think?
Okay, 45% of you have voted. 76. 81 of you have voted. Thank you very much. Looks like it's coming in at 92% of people are saying C, Nick.
Yeah, by clinical examination. As I said, there's no test for Parkinson's disease. You can do some tests and have a look and try and visualize the substantia nigra and the amount of dopamine in it, but you can't always do that. So it's mostly a neurological diagnosis. Now, we artificially sort of deal with it in 4 clinical management stages. This is to make life easy, really, for us and the local clinical team. We look at the diagnostic stage, so it's really important to try and exclude other causes of sort of slow movement and stiffness. And we particularly look at drugs and things. There's the maintenance stage where we treat people and look at complications and things and any deterioration in their general health. And there's what we call the complex stage where drugs don't work anymore. And then a palliative stage where all we can do is help support them and treat symptoms, etc. So what drugs are used? Well, the commonest one of all is levodopa or L-dopa. This is converted into dopamine in your brain, and most people have a really good initial response, but generally after about 5 years it tends to fluctuate and decrease. You can use what are called dopamine agonists. These effectively act like dopamine in your central nervous system, but they're not as effective. And then there's salicyline, which decreases the breakdown of dopamine in your brain. This next picture shows you those 3 drugs and how they're affected, and you can see that levodopa is changed to dopamine. Dopamine agonists lock in with the dopamine receptors and cause action potentials, stimulation, postsynaptic membrane. There are other treatments, and one of them is what's called deep brain stimulation, and you may well have heard of this. It's not used a huge amount. The good thing about it is it doesn't involve destruction of brain tissue, so it's reversible and can be adjusted as the disease progresses, or as it says up there, adverse events occur. So what main drugs, can you remember, are used in the treatment of Parkinson's disease? Have a go at this next question.
Okay, so that looks about 97% are saying A, Nick.
Which is correct. That's the commonest drug used in the first instance. Okay, so that's a short presentation on Parkinson's disease.
Okay, just to remind you that if you've got any questions, thanks for all your comments so far, but if you do have any questions, just type them in and we'll forward them on to Nick as we go.
So we'll have a look at multiple sclerosis now, which is, I think, often a thing that both underwriters and claims assessors find difficult, partly because of the information that they're provided with is not always adequate. Now what we're going to talk about is neurons really, and again, as with Parkinson's disease, it's important to have some understanding of the anatomy and physiology of the central nervous system. And again, much of this is online and pre-course, but what we're going to do is have a brief skip through neurons and stuff like that. Let me just change to the next slide. That's it.
Just to interrupt you briefly, Nick, actually a question has come in. Why is deep brain stimulation used? Rarely.
It's just not a very common thing available at the moment in many areas. But it is, and you need to carefully select patients as well. The Onset says, I don't know exactly the percentage of people that are treated like this at the moment, but it's not that common at the moment.
Great. And just to say to people that, yeah, copies of the presentation and the full recording will be available online after the webinar, maybe later on this afternoon. Thanks for your questions, so keep them coming.
We need to now think about movement and sensation because, of course, multiple sclerosis involves not just movement like Parkinson's disease, but also issues around sensation. The important thing is that movement and sensation depend on intact nerves in our nervous system. It enables us to transmit impulses really quickly in a two-way direction from the brain down to, say, things like muscle, but also from sensory organs back up to the brain. And this enables us, for instance, if we prick our finger or stick it over a hot plate, to remove it quickly. That's a reflex action, but anything slower would go via our brain as well. Now, one of the issues is, as we talked about in Parkinson's disease, nerve cells don't make direct contact with each other. They communicate by a thing called synapses. And that was the issue in Parkinson's disease. Dopamine was a neurotransmitter. There wasn't enough of it, and so the transmission didn't go from one nerve cell to the other. Each axon, each nerve, transmits nerve impulses at a constant speed. So information in our nervous system is therefore encoded using the frequency of nerve impulses. It's a bit like Morse code, really. Sorry, moved on to one. Don't know why. We'll have a quick look at a neuron. I'm sure you'll all remember that basically neurons aren't that different to any cell in the body. They've got a cell body which consists of a nucleus, cytoplasm, and plasma membrane. But specifically, they have dendrites and axons. And the dendrites and axons have synaptic terminals. And this picture on the right is of a brain neuron stained in a special way so that the dendrites and axons show up black. Now, neurons all right, somebody's passing me a message about moving the slides too quickly. Sorry if it's a problem. The neurons are really specialized cell, and you can see, although there are variations in them related to function, some of them have more than one axon, for instance, and stuff like that, they basically are all the same, really. They contain the basic parts. Not all nerve cells have a myelin sheath, as shown here, and we'll get to that in a minute. Now, dendrites are the terminal portions of a neuron that bring impulses towards the cell body of the neuron, while axons transmit information away from the cell body. And what you'll see is when you look at diagrams, for instance, of the spinal tract, particularly the tract from the motor cortex down into the spine, you'll see these long lines drawn in, and these are the axons. So you can have an axon that goes from your motor cortex all the way down to the lowest thoracic vertebra, which is where the spinal cord ends. So they can be very long, and they take information from the nerve cell down the spinal cord. This is another stained picture. One of the problems with diagrams is that they make it look as though it's really easy to distinguish between dendrites and axons, but in fact, as you can see from this picture, it isn't really. In the diagrams, the dendrites are always shown as sort of thin, filamentous things, whereas the axon looks thick. But you can see from this, the dendrites are actually thicker than the axon. Some of this is a bit difficult for you to grasp, but don't worry about it. Again, we've got quite a detailed discussion of neurotransmission that's available in the introductory sessions to this sort of course. So let's ask you another question about this. Which of these statements do you think is correct about human neurons?
So just while you're all responding to that, of course Nick is referring to the courses that we're running in May and June, which go into things in much more detail. We do appreciate that it's probably your lunch hour at the moment and we're hitting you with a lot of information. So thank you very much for taking part and taking part in the polls as well. It looks like 78% of you, 80%, and it keeps going, are responding, so that's great. It looks like, Nick, we have 97% saying
Yep.
B.
Which is correct. They have both dendrites and axons. And you remember, they can't communicate directly. They communicate through synapses. And of course, this is one of the issues around lots of neurological disorders, including Parkinson's disease, but things like myasthenia gravis and all sorts of things. Depending on which neurotransmitter is the thing that spreads the message from one neuron to the other across the synapse. So we're going to talk about synapses. How do neurons carry messages? Well, although it's an electrical message, it's actually an electrochemical message. Again, it's difficult to explain it in short, but what happens is that chemicals, ions, move in and out of the nerve cell and they produce an electrical impulse. This signal, also known as an action potential, then travels along the nerves to an end organ or to a synapse with other nerves. At the synapse, as we've said before, these nerve impulses are converted effectively into neurotransmitters. What happens is the nerve impulse reaches the presynaptic membrane, and there are little vesicles that hold lots of different neurotransmitters, and these are released and they pop across the gap, the synaptic gap, and then they engage with the postsynaptic terminal, and they cause a change in the chemical balance of the terminal, and this creates another electrochemical signal. So you can see it's quite complicated, and there are plenty of places for things to go wrong. Interestingly, there are over 50 known neurotransmitters that are used throughout the human central nervous system and peripheral nervous system. Some of them are excitatory, so they stimulate the postsynaptic membrane, but some of them do the opposite, and they inhibit it. And this balance can be quite important, and is an issue in other neurological disorders. So we need to move on, if we're talking about multiple sclerosis, to myelin. As I'm sure you know, it's a fatty substance that covers some axons, not all of them. And if the axon's covered in myelin, the information it sends, using action potentials, can travel faster than axons that don't have myelin. It's produced by the supportive cells in the central nervous system, and we call them glia, and there are several of them, but there's one main type that produces myelin. There are various breaks at various points along a nerve, and we call these breaks nodes of Ranvier. And these are really important because as the action potential passes down the nerve, it actually jumps from one node of Ranvier to the other. And we know then that these allow these impulses, these action potentials, to travel much faster down the axon. So this next slide shows you, firstly, the top diagram is an axon with myelin, and you can see the nodes of Ranvier, they're the little gaps between. The diagram down on the left-hand side shows you how myelin is produced by one of the glial cells, in this case a Schwann cell. And what happens is it wraps itself around and around and around the neuron to produce the myelin sheath. And the diagram on the lower right, you can see the arrows are meant to represent the action potential, and you can see that it's jumping from node to node to node. So let's have a look at another question. Which of these is the correct answer about myelin?
Okay, thanks very much for voting. Looks like 83% are saying B there, Nick. And we've got about 11% actually saying C as well. But 82% is the highest for B.
That's the correct answer. I think you're getting slightly muddled, that those of you that said it covers all the neurons in the nervous system, because if you remember I said that not all neurons are covered by myelin. So but the majority of you got the answer correct. The correct answer in this is it's a fatty substance. It's certainly not carbohydrate. And as we said, the nodes around here don't delay transmission, they actually enhance it. So let's move on to the next slide. What is multiple sclerosis? Well, as I'm sure you know, it's an autoimmune disorder, and the autoantibodies disrupt and destroy the myelin sheath, so they cause demyelination in the central nervous system. And we'll come on to it a bit later on, but it actually has even more significant effect. It isn't just about the destruction of myelin, it's about their effect on nerves as well. So multiple sclerosis is an interesting disorder. It doesn't determine between individuals, and it affects people of all races and groups, and it's seen all over the world. In fact, it's the most common demyelinating disease and the main cause of neurological disability in young and middle-aged people. You'll see that in the UK the prevalence is between 100 and 200 per 100,000. I'm not sure why there's quite a wide range, and it may represent the fact that it's actually quite difficult to diagnose, particularly in the early stages. Traditionally, we've said the incidence is greater in women than in men by 2 to 1, but there's now evidence that over the past 20 to 25 years, the incidence is changing even more, and we think it's now over 4 to 1, so 4 women against 1 man. And interestingly, if you look at graphs of the incidence or prevalence over the last 25 years, the incidence in men is unchanged, virtually unchanged, so it remains at 1, whereas the women are increasing, and we really don't know why that is.
Nick, a question's come in. Why are only some covered in myelin?
Some nerves in the central nervous system, particularly in the autonomic nervous system, don't require myelin because it's perfectly reasonable for them to transmit information at a slower rate. It just depends what the nerve's for, in lots of cases anyway. The other thing of interest is that the age of onset is roughly between 20 and 40 years. In fact, you can draw diagrams of it, and you can see that the greatest incidence is around, I'm just trying to think of it now, between 25 and about 40 years, actually. And the adult onset accounts for over 90% of them. About 5% of people with multiple sclerosis present under the age of 18, and about another 5% present over the age of 50. But commonly the age in which you start to present with multiple sclerosis is somewhere between 20 and 40. So we'll move on. You need to think now about the etiology of it. Like a lot of neurological disorders, we're not really sure what causes it. And it probably is, again, multifactorial. Many diseases have some sort of genetic basis to them, but we're not quite sure of the effect of it. But certainly in multiple sclerosis, we know about the HLA-DRB1 gene, which, as you know, is a human leukocyte antigen gene. But we also know that vitamin D and sun exposure and certain viruses like canine distemper, herpes, etc., they all have some effect on the etiology of multiple sclerosis. We just don't know the significance of them. Remember that the course of the disease is really variable. It varies considerably from one person to another, depending on the stage that they are, and whether they're in remission and how into recurrence they are. So what do we make the diagnosis on? Well, again, mostly on clinical grounds, but this can also be supported by a range of tests, particularly imaging, MRI, and CSF analysis And in many people these days, we look at evoked responses.
Okay, so a question's come in actually, Nick. What is the role of vitamin D deficiency? And is there strong evidence to suggest a link between vitamin D deficiency and MS?
There isn't strong evidence. There's sort of anecdotal evidence about it in a way. I don't think any studies have been done into it particularly. But for instance, we know that the further you move into the northern hemisphere, the higher the incidence of multiple sclerosis. So the less sun you have access to, the higher the incidence and things. I don't have to hand the exact figures about vitamin C, vitamin D and sun exposure, but I'll see if I can find some papers on it, and I'll give you some references to have a look at. So like I was saying, the diagnosis is essentially clinical, like a lot of neurological disorders, and I'm sure you'll know about the McDonald criteria, which is what's required of clinicians these days before they make a dose of multiple sclerosis. Now for you, I think the difficulty lies in the point at which you're told this person may have multiple sclerosis. And not all of the tests and things may have been done at the time that you are told this by the customer, particularly in terms of claims. And you might have to wait after the claim is made until you're able to say, oh, this person meets the McDonald criteria. These criteria were developed in 2001 by an international panel, and they revised the diagnostic criteria to look at it and make it more easily understandable, not just by clinicians, but also by patients themselves. So have a look at this question and choose the most appropriate answer.
Okay, just to say we're getting quite a lot of questions here, so we'll try and stay on top of them. But as mentioned earlier, if we don't get to respond to you now, we will email you and get back to you. So for the moment, if you don't mind, we're just concentrating on the poll that we've just released. And it looks like 100% is saying 2, so I think that's B.
Yep, and they're right. The age of onset is commonly between 20 and 40 years. That's true. So we'll have a quick look at symptoms and how people present. As I said, it's really difficult. They can present in any way, including sort of depression and things. Commonly, people present with visual disturbance, but not necessarily. They may have problems with hearing and balance. There are motor and sensory disturbances, and you'll know that central sensory disturbances are really common presentation, numbness and change in sensation and things. And very occasionally people can present with autonomic symptoms, but often they end up with a mix of all these things. Some people divide the symptoms into early and late, and these are often discussed, and the appropriate evidence is discussed at the face-to-face sessions. So just as a reminder, have a look at the next question. What criteria are used in the diagnosis of multiple sclerosis?
Okay, just while people are answering that poll, there's a question come through, Nick. Can you see the last one there? Does the severity of the presenting symptoms have any correlation with how severe the condition will be?
No, not necessarily. People can present initially or the second time with quite severe and quite disabling symptoms that, particularly in the first presentation, may actually revert back to almost normal. So somebody that's got really bad sensation in their leg or difficulty with movement, they actually might revert back to having a normal gait and stuff like that. So no, certainly not at the first presentation. As far as I'm aware, there's no correlation.
And then is
the isolated episode of optic neuritis. That's difficult to say. I think most people would accept that it's certainly a significant sign if people have problems. That it's certainly a more, if you like, a hard sign than, say, I don't know, numbness in a finger or numbness in a leg or something. Yes, because what it means is visually evoked responses are that you show a person a certain pattern on a screen and you record from the occipital cortex, and you look at the time that it takes for this visual stimulation to reach their occipital cortex. We know what the normal one is, and if it's delayed, you can tell that they've got something wrong with the neuronal transmission. This is almost always due to demyelination, so it is significant, and there's a way of telling if you use visual evoked responses.
Okay, just to answer the poll there, 97% are saying D.
Good. We've only just covered it, so that's good.
Okay.
McDonald criteria, really important for
Excellent.
working out, especially for claims people.
Great. Just a reminder, lots of questions are coming in, and if we don't get around to them, we will answer them after. But it's great that you're participating. Thank you very much. Keep them coming.
So we'll just move on to the next slide. Now, we talk about types of multiple sclerosis, and this might answer some of the questions that people are asking about the frequency of relapses and things. The answer to this, does the frequency of relapses represent a more severe case, is quite difficult to answer. We'll go through this slide, but not in great detail because you can read it, and then I'll show you some diagrams you may well have seen before. That we split multiple sclerosis into sort of four main groups. It's a slightly artificial split. But we talk about benign, where there are minor symptoms that don't worsen with time. Then there's this thing that you'll all be familiar with, the relapsing and remitting form, where people start by getting sort of minor symptoms or perhaps visual problems. It clears up, as I've said, and it can clear up in the first instance back to normal. And then other symptoms recur. Then there's what we call primary progressive, which is where these people just progressively get worse. There's no remission at all. And then you can get a thing called secondary progressive. And I'll show you this on the next slide. And we think that these different forms represent the differences between what's happening in people's nervous systems. And so these are the diagrams. Now, if we look at the primary progressive one, the bottom one, there's some indication here that whatever causing the problems is obviously not repairing, if you like. And we know now that not only do people lose their myelin sheath, but they also get damage to the nerve underneath it. And it may be that primary progressive multiple sclerosis represents a sort of permanent damage to the nerve. Nobody's really sure, but that may be an explanation for why it looks like this. You can see the benign one at the top. They get problems, and it all reverts back to being normal, and they've got no disability. And then the common one we're used to, which is this relapsing and remitting multiple sclerosis. And what happens is they never quite recover and get full activity or full sensation back in the limbs or the areas affected. And so as time goes by, they gradually get worse and worse. So their disability increases as time goes by. This is just a demonstration for you of what demyelination looks like. Now again, these are schematic demonstrations, so they certainly don't look as easy as this to discern under a microscope if you take a biopsy or after somebody's died. But what you can see generally is the principle that as the myelin sheath decreases, so action potentials travel more slowly along the nerve, and you can see that on the diagram on the right, the nerve fibre is exposed, and sometimes this can be damaged. So how do we treat it? Really, there's no treatment for multiple sclerosis that's uniformly effective between people, and it's quite important because there's a range of severity of symptoms, and it's very variable. Things like fatigue and cramps and pain are disabling to people, even if they're able to move a limb and they start to recover. So these things affect the outcome. But you can give symptomatic treatment to people to help with the symptoms, and you can ask them to change their lifestyle. Now, recently, the treatment options in relapsing multiple sclerosis have been split up into these three routes: symptomatic control, established disease-modifying drugs, and then experimental drugs. So let's have a look at these treatments in more detail. Sorry. What we call route one, the symptomatic, what we tend to do is what we used to do all the way along, is we give people pretty high doses of steroids to control the symptoms as soon as they get them during acute phase. Route two is where we use established disease-modifying drugs. And then we split these into 3 tiers. Commonly we use sort of things like interferon beta and stuff like that we've used all along, and we think they reduce the relapse rate by about 1/3. And then we use these new drug, oral fingolimod, which is immunomodulating, so it affects the immune processes happening in the body. Now this is an interesting drug, A, because unlike interferon, you can give it orally. Interferon is given by injection. And B, we think it's probably going to get accepted and be licensed somewhere during this year. And then there are monoclonal antibodies that can also be used. Route 3 are experimental treatments that are still parts of trial, or certainly won't be used, and one of them is oral dimethyl fumarate. You're only likely to see these sorts of things if somebody's taking part in a drug trial and you've got a report from a neurologist to say that they are. The important thing also is to think about survival. We tend these days to think that survival is normal if people are treated and they don't develop any secondary complications like, say, I don't know, a pneumonia or something, if they're unable to breathe very well. But it's certainly about 30 years from the date of diagnosis.
So we have a couple of questions actually, Nick. Does the frequency of relapses represent a more severe case?
I'm trying to see it. Yeah, certainly frequency of relapses, particularly if you've got the relapsing and remitting condition, as you can see from the graph. We'll go back to it a bit if I can. That one. You can see that as they relapse and remit, they get left with a level of disability each time. And so I presume the more frequently you have your relapses, the more likely you are to end up with disability. Let's have a look at another question. Would there be an obvious difference between the appearance of demyelination in benign MS and in progressive if you compare the neurons? I don't think so. To be honest, I've never seen anything written about this, but I think demyelination is demyelination, and I think probably, and this is just an interpretation, I don't have any evidence for it at the moment, it may actually be more about whether the nerve is damaged underneath or not. So it may be that in benign demyelination you just get demyelination which affects nerve transmission, but there's no damage to the nerve, and so you make a fairly full recovery. But the honest answer is I'm not sure about that. Again, we could look it up. I'll give you some information on the internet when I find out about it.
In relapsing remitting MS being treated with beta
interferon. But then a patient stops this due to side effects. How much will it affect the progression of the disease and therefore the mortality? The answer is I don't really know. We do know that if they stop their interferon, they tend to go back to getting sort of more relapses because the interferon in some way prevents them, the frequency and possibly the severity of relapses. I think you could say that it therefore certainly be associated with increasing disability. The honest answer is I don't know about mortality. I just looked at the mortality figures on average.
Okay, and one last question here. How do you work out who gets what
type of treatment? The honest answer is I haven't put that up as a slide because it's really complicated. Professor Robertson here gave me some information about it, and I looked at it and thought in such a short period of time it would be difficult to explain how we do it. And it uses several indicators, but again, what we can do is we could give you an indication of generally who would get it. Of course, to some extent, it's also up to the individual doctor as to who's treating the patient as to what they're likely to get.
Okay, I said that was the last question, but actually, here's one more. Can the diagnosis of relapse remitting change to progression over time?
Well, as I said, one of the problems with these terms is that they're slightly artificial. I think it's quite possible, probably, to get relapsing and remitting. Certainly it changes into a more progressive type, but not necessarily progressive on its own. It varies from time to time. Okay, so that's the end of the presentation. Hope it was helpful and look forward to answering some of your questions.
Yeah, I mean, we're just conscious of time, so we're going to just finish off the questions there, but I can see they're still coming in, so thank you very much for that. Do keep them coming. I think it will be open for certainly another 5-10 minutes, and we will respond to them, so thanks very much. Well, I just would like to say, as I said at the start, as mentioned at the start of the taster session, this is a taster session for our Assessing and Managing Medical Risk for Insurers courses, which are running in May and June. And as you can see on that slide there, it gives you a web link as well. These are blended learning courses, so a mix of online and face-to-face teaching. So do have a look at our website for more information. There will be a brief survey released to you for feedback on the webinar, so we'd really appreciate you taking some time to complete that and give us some feedback on it. And if you have any photos, we are aware that some people listening in are watching with a number of colleagues around a computer. It would be great to see how you watched the webinar, how you took part, and like I was trying to say there, on the polls that were released, at least 85–90% of you were actually responding, so thank you very much for that. So if you do have any photos, then tweet them to us or just send them on email to Charlotte, and because it would be great to share those with people. So, as I said, this is the first webinar that we've ever run. So, thank you very much for taking part. Apologies if you had any black boxes around your screen at different points. I'm not quite sure what was going on there. But thank you very much for taking part. Thanks for your questions and all your comments there. But I would very much like to thank the support team here, Charlotte in particular, who set the whole thing up, Gail, and also Katie, who's been on our Twitter account there, sending out tweets throughout the hour and also responding. But of course, I must thank Nick for the excellent presentation and the responses to all the questions. So thank you very much for taking part, and hopefully you will go online and have a look at the courses that we have running in May. But thank you very much. Clap, 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 everybody. Take care and have a lovely weekend in sunny Cardiff. Or come to sunny Cardiff, because you aren't. All right, take care. Bye.